All right. Well, good evening, everyone, and welcome back to the Diversity in Medicine webinar series. Very excited about tonight's guest. Before I get started with that, just a few housekeeping notes. We always want to maintain an open and engaging session. So if you can, we encourage you to keep your camera on, especially if you're asking a question. We understand if you can't, if you're in a location where that's not possible. So if you're not speaking, please remember to keep yourself on mute just to avoid any background noise. And if you have any questions, and we absolutely encourage you to ask questions, please let me know. You can raise your hand. You can just pipe up. I will try to give space for people to ask questions. You can also type your question in the chat, and I can try to call on you, or anything goes. This is an open session. We certainly want you to feel that you get your questions asked and answered, so don't be shy. All right, so I'm going to start tonight with a brief introduction of our speaker, Dr. Carla Boutin-Foster. Dr. Boutin-Foster is currently the Associate Dean of Diversity Education and Research at SUNY Downstate Health Sciences University. Dr. Boutin-Foster completed her residency in internal medicine at New York Presbyterian Hospital and earned a master's in health services research and clinical epidemiology from the Weill Cornell Medical Graduate School of Medical Sciences. She was the chair of the Minority Health Council of the New York State Health Department and has published several peer-reviewed articles that focus on cardiovascular disease disparities in the biomedical research pipeline. In addition to her research, Dr. Boutin-Foster's position as Dean of Diversity Education and Research allows her to work closely with medical school students and provide mentorship to those students throughout their medical school careers. We also say that she is a member of our AMSNY Committee on Diversity and Multicultural Affairs, and is an incredibly valuable member of that committee and contributes all the time to our work here at AMS, and we greatly appreciate it. So welcome, Dr. Boutin-Foster. Thank you so much for joining us.
Thank you. Thank you.
So I thought I'd start tonight by letting you tell us a little bit about your path to medicine and particularly research as a physician. You're here to talk about physician scientists and the work that you do.
Sure. Why not? So I'll go even further back. So I was born in Haiti. I went to public school in Brooklyn. My undergrad was at NYU, and then Downstate, SUNY Downstate. Graduated in 1994. I did my residency in internal medicine at Weill Cornell, and I wanted to be an internist because I loved every aspect of medicine. I loved pathophysiology, pharmacology, and there wasn't one specialty that drew me more than any other. But I knew that surgery, while it's an amazing field and specialty, that it wasn't, I probably wouldn't do well in surgery since I passed out in the OR a couple of times during third year, but don't let that deter you. Surgery, I mean, I am so, I think all of my surgical colleagues are awesome. And honestly, if I could just stand up during surgery, I'd probably be a surgeon. So I say that pick your passion, and make it work. Whatever you select, you will do well at it if that's what you really want to do. So after residency, I was confident in my ability to take care. Well, I was confident in my ability to recall medical knowledge and to apply medical knowledge. So that's what SUNY Downstate did for me. And then after residency, I was confident in my ability to take care of patients. But I thought there was more to do, and I would see my patients come back with similar concerns. And, I felt that I could take care of my patients one-on-one, which was great. It was a tremendous opportunity to do that. But I wanted to find out about families and their community and what informed some of the decisions that they made, especially around health. And I realized that I needed additional skills. I did a health services research fellowship. It was a fellowship. It was a fellowship for health services research and clinical epidemiology. And it's really just a research fellowship. It really provided me with the skills to ask and answer questions, hypothesis driven, and to analyze data and disseminate it. And that was, I mean, that decision changed my life. So after residency, I did a 2-year fellowship. And that's where I met my mentor, who's still my mentor. And that was my path to research. It was really getting a set of skills that would allow me to ask and answer questions systematically and apply it. And here I am.
Great. I know you mentioned just now mentorship, and I know in prior times when we've spoken, you've talked about the importance of mentorship and the importance of mentorship in your life and being a mentor. Can you tell us a little bit about that and how that's worked for you?
Oh, wow. Mentorship is so important. So I've been tremendously blessed to have, like, my mentor was my boss. She was like my mentor mom boss. Her name is Dr. Mary Charleston, if you ever have an opportunity to meet her. So after residency, I did this fellowship, and Dr. Charleston was the director of the fellowship that I did. And then after the fellowship, she offered me a position to stay on to be basically a research coordinator of one of her projects. And I did that. And I still wasn't quite sure, like, if I was going to do this, like, I saw myself doing research in addition to clinical care. And so she, provided me with the skills. And then I was reviewing papers with Dr. Charleston, and the next thing you know, I'm writing grants. And grants are very addictive, right? Like, you write a grant, sometimes it's not funded, right? And that's okay. It doesn't mean that it's a bad grant. It's just that there's a limited amount of funding out there and a lot of grants, right? And then you're like, I'm gonna get them, and you start writing again, and I can lose myself. I can spend weeks writing a grant and you never see me. And then I'm like, wow, I like this. I'm like, I don't believe I really like this, but I did. And Dr. Charleston was very supportive. She's like, don't worry about it. You'll get another one, right? She's like, and she's always thinking, she's like, the study section, they don't know what they're doing. They don't know what they're doing, right? So I started writing grants. And then when I started getting, grants funded, it was just very rewarding. And so she was my mentor because she provided me with the skills that I needed. She led this program, but she also was what I would call a coach, right? After she knew that I had the basic skills for grant writing, she kind of ran alongside me, and no longer was she writing a grant and I was just adding to it. She allowed me to write the grant and she was adding to it, and she would say, no, you don't want to say this, you don't want to say that, to the point where she was just making minor edits. And in addition to doing that as like sort of my coach to make sure that I applied my skills in a way that was productive and efficient and to maximize what I knew, right? She was like, you know how to do it, but this is, it's kind of like a coach, like, you know how to run, but you have to, pick your feet up this way or angle your body or pivot or something. And then she was also a sponsor, right? So she was a sponsor because she would go ahead of me. She would go to meetings that I wasn't invited to because, she's Dr. Charleston. I wasn't invited to the meetings, but she's like, oh, I went to this national meeting and I met Dr. So-and-so and I told her about you and I set up a call with you. And I'm like, what? You did what? And then the next meeting I would go and she would introduce me to her colleagues. And every chair that we had when I was at Cornell, she would introduce me to the chair. She would just set up a meeting for me to meet the chair. And I would get a phone call like, Dr. Jones wants to meet you. And I'm like, I don't even know Dr. Jones yet. She just came on board or he just joined. And Dr. Charleston would say, yeah, because I know that you wouldn't call them, right? I know you wouldn't call your chair, but you need to meet your chair. So she was my sponsor in that way. The other thing about Dr. Charleston is she, one thing that I really admired her was that she recognized that as a Black woman, my experience was different from hers as a white woman. And she never said, oh, Carla, I know what you're going through. As a matter of fact, she's like, I don't know what it's like. right? And she's like, I know that this was messed up, if something happened and I told her. And she was very supportive, and she would say, you need to say something about it. And if you're not, I am. So she looked out for me, right? And she used her privilege as a white woman to make sure that doors that I couldn't open by myself, or that wouldn't be open for me, or that would probably be closed, she opened the doors wide open. And if anyone dared to say anything, like Dr. Charleston would just go, she'd go all out. She really was. So that meant so much to me, because she understood that there might be challenges along the way, that I might face barriers because of the way I look. And she understood that. And she was prepared to really stand in the gap for me. And that is something that it's important that mentors appreciate that, especially when it's when the race, ethnicity, gender, identity, orientation between the mentor and the trainee or the student are discordant. And if you have an opportunity to mentor and you're able to open a door or step in or knock down a door for someone who you're mentoring, use that privilege. Really use that privilege, because she made phone calls to the NIH that I'm like, I can't make that call. She's like, I know, I would. And she did it. So my mentor was very instrumental in my life. She knows my kids, she's the, it's like she knows, and it's not just me, I would be selfish to say Dr. Charleston only treated me this way. All of the people that called her mentor, this is how she treated them. So I would say find a mentor, but it's also bi-directional, right? I think the thing that worked between Mary and me was that Dr. Charleston is that if she needed something, I would do it, whether it was writing a grant. And I believe I also enhanced her career as much, perhaps not more than, but as much as I was able to in my capacity, enhanced her career, right? Because she's mentoring me. She wants to get grants. She wants to get funding, right? And if she's spending all of her time mentoring me and I'm not contributing to her getting to the next level, then it becomes like she's carrying me, right? But I was able to contribute to grants that she got funded, reviewed grants that weren't funded, present papers when she couldn't go. So she was able to support me in my career while moving ahead in her career. And I think it's also important to realize that your mentors are mentoring a lot of people. And as much as you can contribute to the relationship, her successes were my successes. If she got another grant, then I knew I was going to get paid because she was my boss, right? So mentorship is key, bi-directional, giving back to your mentor in a way that enhances their career as well.
Wonderful.
If I can just interrupt for a second. I just got off a call where we were talking about mentorship. And one of the people on the call was talking about the idea of sponsoring, having somebody, and you mentioned that. And I'm just wondering if you could say a little bit more about what that really, in terms of mentoring, what does that mean to be a sponsor of someone, or how to take that sponsoring if you are someone, because they were talking about, it was a part of mentoring that I was not familiar with. And they were talking about how important it is to do this. So.
Yeah, no, I think Dr. Charleston was a mentor. She coached me and a sponsor. So if you think about a sponsor, they will pay for you to get somewhere, right? And that's what she did. She opened the door for me, right? So you could pay to send someone, but she just went there and opened the door for me. So she paved the way, she made the way. And you can be a mentor without being a sponsor. So you can be a mentor that just says, I'm going to help you get your grant, but you're going to need to, you're going to make the phone calls. You're going to go to these meetings, right? And you can be a sponsor and not be a mentor, and say, you know, I'm really busy right now, but I'll give you I will set up this meeting for you, right? But you got to know what to say when you get there. So she did both. She paved the way, she opened the door, she paved the way for me to get there. And when I was there, she made sure that I said the right things. She made sure that I had a follow-up meeting. Like she would say, okay, so you just met with your chair. When is the follow-up? I'm like, well, I don't know, right? She's like, okay. And she would call the assistant, right? And that gave me, you know, and at some point you have to do it yourself, right? Like I wish I could call Dr. Charleston and say, yeah, you know, I want to negotiate. Can you do it for me? So a sponsor goes ahead of you. A sponsor makes it easier for you. And a sponsor will really just put you in positions so that you can demonstrate your skills. That's the other thing a sponsor does, right? So the sponsor so someone may not sponsor you if they don't think you have the skill set, right? So she's not going to introduce me to like NIH leadership if I haven't demonstrated that I know how to do research and I can answer a research question and I can answer my studies, because that would be embarrassing, right? So a sponsor looks for you know, talent that has someone who has the skills, someone who's been coached, and say, oh, you just need a playing field now, right? You just need to show, you just need a stage. And I'm going to book you this stage and you're going to go there and I'm going to pay for it. I'm going to pay for your trip. I'm going to line up everyone and you go and you show them what you got. But they have to trust that you will do that, right? But it goes back to being bi-directional. I think your mentorship relationships are more productive when every step of the way there's this bi-directional sharing, right? You know, because I have to be able, so the people I meet that Dr. Charleston introduced me to, it's important for them to go back and say, hey, Mary, I met Carla, really talented. All right, so we're working on this grant together, right? So that's, you know, I believe that's what sponsors do. Someone who's going to not just show you what to do, but take you there as well.
Right.
So you were fortunate to have an amazing mentor. How can our students, I think one of the things I hear a lot when we do these webinars and when we talk to students is, how do I find a mentor? How do I find the right mentor, the mentor who's going to be all these things, or, you know, really go to bat for me? And especially if you're coming from a background that is underrepresented, if you know, you're not going to be necessarily able to find a person who's concordant with you. So how do you find these people and build those relationships?
Oh, that's an excellent question. Well, first, what Ms. Hassler said, it's true. You may not find a mentor who from the same race, ethnicity, orientation, identity, and that's okay. That's okay, as long as they respect that there are differences and different experiences, but they embrace the opportunities for similarities, and that similarity is a shared vision of you, right? If they see you where you don't see yourself yet. And to find a mentor, you know, you email someone, but you have to do your research also, right? You know, to email someone, say, I would like you to be my mentor because your name begins with a C and so does my name, right? Like, no. I looked at your research. I'm interested in this. This is what I started doing. It would be helpful for me to learn more about what you do, right? And you don't have to necessarily make a commitment at that time, right? I would like to find out more about your research. And again, it's important to demonstrate to the individual that you actually are interested in their research because you looked them up, you saw what they did, right? And you come, you know, can you tell me more about this study? You know, I was interested in this question and you found no difference. Why do you think that is, right? And then again, mentors, you know, mentors, scientists, they enjoy science. So they enjoy talking about the science. So I say, do your research, email people, right? And it's okay if you meet someone, you're like, I really don't want this person to be my mentor. So the first call is not, can you be my mentor, please? Is, I'd like to find out more about your research, right? And if you're like, wow, I would see myself working, can I follow up with you? And then, okay, we have our second meeting. This is what I did. Can you take a look at this? And the next thing you know, it's developing organically. You have your mentorship relationship, but it takes time. It may not happen on that first encounter. And have multiple mentors. Right? Have multiple mentors. You don't need to have only one mentor. You can have a mentor who's going to help you with your research. You can have a sponsor, someone who's known, you know, in the field that you're interested in. And sometimes they know your mentor, sometimes they don't know your mentor. And you can have career mentors and life mentors, right? Or life coaches, people who are just trying to enable you to sort of maximize and leverage your skills. So you don't need one mentor. As a matter of fact, when you're applying for NIH grant or career development award, they ask for a network of mentors, right? Mentors who know each other, who know your work, and who are going to work collaboratively and who contribute to different aspects of the research. And especially if when you're writing your letters, it's really important to have different letter writers.
Great. Do we have any questions so far? I'm just going to take a pause and let people hop in if they have any questions. Okay. So I was going to ask a little bit more about your NIH funding. You have research you've done with the Comprehensive Center of Excellence in Disparities Research. NIH has typically not allocated a tremendous amount of resources to disparities research, and I'm interested to hear more about the work you've done and that type of research that you are doing as a physician scientist.
Sure. May I just ask, just by show of hand, how many people are interested in research, or you're thinking about research as a research career? Maybe, maybe not. Okay. All right. So let me start. So when I left college, I had no idea that I was going to do research. When I was in medical school, no idea I was going to do research. And in residency, I wasn't quite sure I was going to do research either. It wasn't until actually I did research. So my idea of research was always something was static, you did it, it was data, it was numbers crunching, but that's not necessarily research, right? There's a whole spectrum of research. There's basic science research. There's lab research where you're working with rat or mice models, right? Or mice, and that's research, that's basic science research. And there's also a whole other spectrum of research where you're doing health policy. And all of that is funded by the NIH. Research for me is just a systematic way of asking and answering questions. And it's asking questions like, how do I get a group of kids to listen to a talk that I'm giving about HIV and AIDS? You know, how do I do that? How do I leverage the resources in faith-based organizations to improve blood pressure control in the community? How do we get Black men to get preventative care, right? So I've had an opportunity to do research in a variety of settings, from listening to, like, I'll get into that a little later, but I research the areas that I'm passionate about. And it's likely that at some point, so we're the second year and third year, right? Right. So at some point I know Downstate has a research requirement, right? Jesse, I don't know about some of the other schools. Do your schools have a research requirement also? Not yet? Okay. So, and your residency may, right? You may have to do a residency research project. And it's really important that we demystify this concept of research. It's really using a set of skills to ask and answer questions, right? It can be, what are some of the facilitators that promote diversity in medical school? How do people cope with COVID? For instance, do communities that have been subject to historical structural racism, redlining, members who live in that community, what is their health like? Even though they weren't alive in the 1930s, but what's the health like? And it's questions like, it's like some of these questions. So going back to the NIH question, the NIH will fund well-designed research. And as a matter of fact, I had an opportunity to chair. It's the Health Equity Promotion Study Section. So it's a specific area in the NIH, that's the National Institutes of Health, that will fund health disparities research. So the NIH, we talk a lot about the NIH because that's the major funding agency that spends billions of dollars on research, period, right? So COVID vaccines, right? We got the COVID vaccine so quickly because we had government, we had pharmaceutical companies, we had Dr. Fauci at the NIH, right? So the NIH is like the place where research is done. They get money, they get funded, they get federal money, and they allocate it to individual investigators to do research. So you basically need a well-designed research project. And it does have a good chance of funding because there was a time, you're right, when it was difficult for health disparities research to be funded. But now they're actually looking for health disparities research. As a matter of fact, there are research proposals that come out saying, what is the role of structural racism, discrimination on health outcomes? We're looking for innovative out-the-box studies with community partners. We're looking for research that address minority stress and its impacts on outcomes in sexual or gender minorities, right? And these, I mean, I've had an opportunity to review a lot of research studies and make, recommendations to the NIH. And the studies are just really, every aspect of health disparities, housing, does providing housing improve health outcomes? So it's some of the things that you think about on a day-to-day basis, right? Some of the things that you think about and you come up with a hypothesis, and that's research. So I really don't want you to walk away thinking that research is not for me, because you probably will, especially if you're doing any sort of residency at an academic institution. You're probably going to have to do you will have to do some sort of research project, and it can be anything. Can I ask just like quickly what people are interested in? Do we have time or no? Okay, so Samantha, what are you interested in?
Oh gosh. Okay, so I actually was going to ask you a question about what do you do if you're interested in everything. So my little life story. So born and raised in Syracuse, I go to SUNY Upstate. I'm a third-year medical student. On my surgery rotation, definitely not a surgery personality, but I think I've committed to family medicine because I like everything. I'm interested in longitudinal care of patients, and I love everything health equity. I was just going to ask you like a question of just like how have you ever like tried to focus it like your health equity like interests like when it comes to research? Because like as of now, like I've been doing like environmental justice, I've been doing food insecurity, COVID-19, I've been doing like curriculum, like can we train students to use interpreters and how does that affect like patient outcomes? Like I feel like I get excited about too many things and I'm not sure if that is a bad thing.
Oh, that is, I think that's great. And in time, you will focus, your questions will be focused, the more research you do. I mean, you're doing research right there to ask, you're doing curriculum, does it work, right? What is the impact on the curriculum on trainees' long-term outcome? Health equity. Again, what is the role of providing SNAP, right? For people experiencing food insecurity. What is the role of that on childhood health? What are facilitators to early referral for birthing people? What are the causes of disparities? So we're doing a research project right now with the Department of Family Medicine, and it's looking at the patient experience. So we know that patients from different backgrounds have differential outcomes and have different experience. We know the impact of unconscious bias, though it's unintentional, it does have detrimental effects on patient outcomes. We know that, unfortunately, there are instances of patient mistreatment, right? So we know all of these facts, all of this exists. So we wanted to know whether or not if we identified negative patient experiences, told the providers that this is what our patients are experiencing in a real-time fashion, would that change outcomes for patients? And would that change providers' perceptions? That's just a quality, improvement project that we're doing with family medicine around health equity, involving patients. It involves developing surveys and disseminating surveys. So yes, it's all of that. May I ask someone else what they're, okay, Dominique.
Hi, how are you? I'm Dominique. I'm originally from Long Island and I'm a first-year medical student at SUNY Upstate. And I also had a question. So I am interested in ophthalmology and like disparities in eye care. And I actually met with someone yesterday in terms of kind of like the things I should be doing now and beyond in terms of setting myself up to be successful residency. And the person, and I was asking like, is it okay that I don't do and I'm not interested in like basic science research, and more interested in health disparities research? They were like, yeah, that's totally fine. It's more about committing to a project, finishing a project and like showing your skills in that way. And then like later on in the conversation, the person they didn't say it like this, but essentially they said like, oh, you also don't want to box yourself in as like, a Black woman being a health disparities researcher. And again, they didn't say it like that, but that's essentially what it boiled down to. So I just wanted to know like how do I respond to that? And like, what's your thoughts about that?
No, I know I've often heard that. So in order to get into ophthalmology, you will have to do research, and research does not have to be basic science. It can be looking at disparities in glaucoma. Right. Developing mechanisms for patients to adhere to glaucoma medications, differential outcomes, surgery outcomes, why are certain groups, their outcomes from surgery differ, comorbid conditions and vision loss, right? So all of that. The thing about disparities research is a spectrum of research, right? From basic science research and epigenetics, when you start looking at environmental factors, race, ethnicity, and genetics, and understanding what are the differential outcomes, right? After you're including also stress and structural factors, and recognizing race as a social construct, that's research, all the way to health policy reform so that medications for glaucoma are not like $200, and understanding why that is. So I think that person needs to realize that there's a spectrum of research that's known as disparities research, and it includes population health, it includes community-based research, it includes translational research, and as long as your research is, as long as you can see how your research can be applied broadly, that's fine. And if, let's say on your interviews, let's say you do, all of your research is in disparities because that's what you enjoy. If you're passionate about that and you say, because this is what I want to make a difference in, right? We know that there are disparities in glaucoma. We know there are disparities in cataracts. We know that there's a reduced rate of referral for surgeries, differential rates of actually having surgery, and you want to be a part of that. And if you can provide the facts, the data that demonstrate why this is not only something that you like to do, but it's something that must be done, and you show the value. I think it's, someone will say that if they really don't understand the impact of disparities on all of us, right? That if we could reduce disparities, how much money we could reduce in healthcare costs, billions, right? Not only direct costs because of healthcare, but indirect costs from, how many people cannot work because of vision loss at an early age? right? So the impact of disparities on health in general are astronomical. And I think it's to help this person to sort of broaden their view on, you know, like say, oh my goodness, and you get excited about it, not so much defensive, but like, oh my goodness, there's so much. Did you know the disparity? Did you know the cost, the how many people have to exit the workforce early because of decreased vision and you know, and people of color are more likely, and the reasons are really not known, and you get excited about it, then they're gonna be like, oh, how do I do that disparities research? I want to do disparities research too. You got to do what you love. You got to do what you're passionate about. And you have to know the data supporting it.
Thank you.
Oh, and sorry, one more thing. Look at the NIH, right? Look at the NIH NEI, National Institute of I and something else, right? And you will see disparities research. And you can say, oh, that's really interesting because I just looked at, you know, the NIH website and they're calling for research on ocular health, you know, at the NIH, right? I just looked at the Association of Ophthalmologic, right? And they're interested in disparities research, right? So you got to fight with data. Sorry, I know we're running out of time. Wilmer, sorry.
Hi there. I'm actually a med prep, so I'm in the I'm gonna start in August, and I'm interested in. I have various interests, but off the top of my head, it would be like autism and something in endocrinology like diabetes, and definitely health disparities as well, and somehow combining all those things.
Oh my goodness. So congratulations for being in med prep, right? So hopefully we'll see you here in a couple of years as an MS 1, 2, 3, and 4. So I was just in a conference call yesterday on autism spectrum disorder and disparities in ASD. And there are a lot of disparities. While the prevalence by race and ethnicity may be similar, right? The rates of referral for early intervention differ, right? The rates of follow-up differ also. There's a lot of stigma that's mediated. So there are a lot of research opportunities in autism spectrum disorders, looking at the sort of the neurodiversity and neurodevelopment, looking at the role of parental, how this, you know, how this can contribute to parental stress if we're not supportive of our parents, right? And the importance to consider a patient's perspective. All of that was part of research. So again, right, look at the NIH and look at the types of research that they're doing, right? Look at the National Institute for, I think it's the NICHD, National Institute for Child Health Development. And you'll see what they're doing, right? The NIH has made disparities a priority. And that's what you can tell them, Dominique, right? You can say over the past year, there have been so many calls for research from the NIH. As a matter of fact, you will not get an NIH grant if you are doing a study and you do not have plans for enrolling racial ethnic minorities, and that you're not looking at gender and sex as not gender, but sex as a biological variable. You will not get funded for that. Okay, so the NIH has recognized the importance to look at the differences in every specialty out there, whether it's ophthalmology, surgery, they all are looking at health disparities. So look at the society, right? Look at the mission of the society and say, oh, you know, that's interesting because this society has diversity, equity, inclusion as a mission, and you want to advance work. And that's what you do on your interviews, right? If you're interviewing with someone, you're like, they're not really feeling disparities, you bring up their mission statement and say, I am so excited about the mission statement that your organization put out that has equity right there. I mean, you're not gonna say it like that, right? But you're like, well, I'm so excited to contribute to this. All right. Do you mind if okay, who else? Jesse. Sorry. Hi, Jesse.
Hi. So for me, I haven't really done much, but when I started, I still want to do general surgery. But then I also started shadowing in the emergency department in Maimonides. And one thing that I noticed that I'm really interested in now is just, well, finding out the great question is finding out why there's such a hesitancy for the minority population to seek healthcare. Because most of the time when I see them in the emergency department, it's like when things are really bad. But like when you see other populations, as soon as it's, you know, the least in, everyone's in there. But with the minority populations, it's like when things are bad, and even when they're being taken care of, there's like, you know, there's a lot of questions like, okay, what are you doing? Okay, I'm not comfortable with this and stuff like that. So that's one thing I definitely want to see and I will look into and see if there's a way to make seeking healthcare more of a thing. Because I mean, for the most part, they don't, depending on your insurance and all that, they don't have to pay for it. But it's still, there's still that hesitancy, even if they don't have to pay for it, it's still that hesitancy to go seek medical care. So that's something I'm really interested in right now.
No, that is such an important question that you're asking. And there's so many important research topics that you can do and apply that to surgery, because patients who present later for any condition may not have the opportunity to have the best outcome, right? And it's looking at that from multiple levels, the patient level factors, as well as the community level factors, structural factors that impede access to care, and maybe institutional factors, right? So working with a hospital and looking at some of the areas that they're interested in, let's say whether it's, presenting for a total joint replacement late, or presenting with renal disease at a later stage, to understand why that is, because that also helps the institution, right? Again, like, as I said, addressing health disparities and addressing some of these systemic factors doesn't only help one race or ethnic group, it helps the entire healthcare system, right? And we're able to save money and reallocate it to prevention. Health disparities cost billions of dollars, not only in direct costs, but again, people who are, if life expectancy is 6 to 8 years less, depending on where you live, depending on your zip code, that means people who could potentially contribute to the workforce are dying at an early age. Right. So I think looking at the broad implications, and that question is really there's so many levels and so many layers to look at.
Thank you.
Is that it? I think other students. Oh, Jasmine is.
I think Jasmine might have joined a little late. I don't know if you are in a position to let us know where you are and what you're interested in. Maybe not. Well, I have a question. In terms of balancing your role as a physician, in terms of a clinician and a scientist, how does that work in terms of the real life nitty gritty? What is a typical day, week, month like for you in terms of balancing those responsibilities? And I know you have academic responsibilities as well now as in admin at Downstate. So let us know a little bit about what that looks like functionally at your level.
Oh, sure. So, well, I can tell you a little bit so right now I'm mainly academic administrative researcher role. But just a few years ago, when I was a clinician, educator, researcher, it was really balancing all three. So a typical day would be coming in, checking email, looking at patient calls, right? Now it would be checking email, looking at if I have a call from a student, or for my dean about, a student related matter, addressing that. And then it's also looking at papers, right? So one of the things about research is that you're always writing papers, you're always looking at papers. So it's looking at papers that I want to submit, looking at papers that I submitted and the journal rejected, or the journal said revise and resubmit. So I have a paper that's like, I have to revise and resubmit. So working on that. And then meeting with people about research. So I have a couple of trainees that I'm mentoring. So, every day or so I have another trainee that I'm mentoring. So spending time talking to them about their research. So that's where I am in my career right now, really helping others in their career to develop their own research career. And then it's grant writing. So you're not writing grants every day. Grant writing is done in like spurts and in like grant writing bursts, really. So you can spend about 2 months writing a grant, submit it, pause, wait, and then another request for an application will come out. So you may write grants, or I write grants. Wow, I probably write a grant 3 times per year in most years, but this past year, there was such a rapid fire of grant proposals coming out. I think we wrote a grant in November, December, January, and February, back to back. But that doesn't always happen. And when that happens, you have to reprioritize. I will not, so things that I will put aside, my papers will be put aside. My students are never, when I was seeing my students and my patients, I would always, drop whatever I'm doing for a student or a patient, or, of course, if my dean calls. But for the most part, I would say, okay, grant writing during these hours, I'm not going to this meeting, right? So I have regularly scheduled meetings, and I'll just say, hey, I'm sorry, I won't be able to come to this meeting, and do that for about a month, miss meetings for about a month, and keep my schedule open for just students or dean or anything that's emergent, and then spend time writing, and then repeat. But it's a combination of things, right? You're in academic medicine, you're always doing different things. And you also have to be really flexible. That's one of the things that I realized, that, something can happen and you need to address it, and you just kind of put it down and you pick it back up. And it's also important not to do it alone. So if I have to put down a grant, there's always a collaborator, and I'll say, hey, can you do this for me? I started writing this, I need to focus on this, and then we come back together. So those are the things. It's addressing urgent needs, keeping up with my papers, looking for opportunities to write grants, meeting with trainees and students on their research projects, and then repeat. But I also find time to spend, time with my family. My kids are grown. My mother-in-law, that was like another tremendous blessing, raised my kids really. And I was okay with it. I had no problem with it whatsoever. Like if they said, Mom, we want to spend the weekend with Nana, I'm like, may I pack for you? Right? I was not like jealous and saying, oh my gosh, they love their grandmother more than me. I'm like, okay. And it was fine. It was fine because I know that she cooked better. I had no problem with that. Right? Like they knew that I would pick them up at 9 o'clock and we would eat mac and cheese at 9 o'clock, and and then we'd go to karate to kind of burn it off, and that was fine. I think you have to give yourself a little grace, knowing that it's okay if everything isn't perfect, and there's juggling, right? But I guess my kids knew that no matter what, like there was someone there for them. So it's important to have work-life balance, to have fun, to watch. I watched Spider-Man this past week and it was awesome. I'm just saying that one of those Spider-Men could have been Spider-Day or Spider-Woman, but anyway, I digress. Maybe the next sequel. But no, have fun, enjoy your journey.
So I have another question. What is it about grant writing that you like so much?
It's the thrill of, I'm going to get it the first time and they're going to read my grant and they're going to be wowed. The other thing, it's very stimulating. It's like writing a song, right? It's like writing a song or creating something, because I get to sit down and read the literature and come up with my own sort of hypothesis or model and put it in, and it's sort of like my masterpiece that I write. That's the enjoyable part. And because I carve out time I'm really focused on it. And it's the science part. And again, you really have to enjoy it, right? I'm like, oh man, oh, so this is what happens. Oh, okay, so this model, maybe this work. And I come up with like new models and I write about it. And it's great when they get a score, right? Which means someone liked it enough, and they may recommend it. And then if it's not scored or if it doesn't get funded, it's like, oh, well, Mary, Dr. Charleston would be like, what do they know? And you resubmit it, right? In the, not to take it personally at all, right? Not to take it personally, because they're evaluating the science and not you, right? And I've had an opportunity to be at the other end of the table and actually review grants. So I know how hard it is, but it's the ability to create something, create a document, and think about it and work collaboratively. It's the science. It's really putting it together. That's what I love about writing grants.
Great. We're nearing the end of our time. So students, please, if you have questions, chime in.
I have one question. I'm not a student, but I'm the intern with AMSNY, and I'm currently in a master's in public health program. Really interested in, a lot of people kind of said this, but really interested in addressing racial disparities in health. My thesis is focused on social determinants of health, so I'm very passionate about those issues. And in one class, you talked about how the NIH has been really focused on disparities research. I don't know if it's recent, because in one class we kind of learned that historically the NIH was very hesitant about funding disparities research, and you see that there wasn't a lot of funding allocated to this research, and then it was typically PIs of color who were doing these research projects. So I was just curious, in your experience, have you seen a similar trend? And based on what I've heard when I joined, it seems like they have been trying to remedy that. So just in your experience, have you seen that there was a hesitancy or there was a lack of funding allocated to this research in the past?
Yes, no, that's absolutely right. I think probably over the last maybe 10 to 15 years, we've seen an increase. So there was the Center for Minority Health, probably in the late 90s, 2000. That center became an institute. A National Institute for Minority Health Disparities, NIMHD, and that center received more funding federally to address health disparities. Since 2020, multiplied, right? So where there are actually requests for applications that specifically mention structural racism, discrimination, in an RFA. And normally you would not see that. You would just see health disparities. But now the NIH is really explicit about the type of research that they're looking for. So it has increased. What you say about PIs of color were less likely to be funded. So there are many papers describing that. And it's because of, at the NIH level, there may have been some unconscious bias in reviewing applications. At the PI level, it may have been the lack of mentorship, right? And also PIs of color were less likely to resubmit a grant. A lot of grants are funded after they're submitted a second or third time, right? I know I've had grants that had to be resubmitted, 2 times at least to get funded. And then the other thing, so those are the reasons. So with the increase in focus on health disparities grants, there's also an increase in addressing unconscious bias in the grant review process. So there's certain things that that cannot come up in discussion at an NIH study section. That there are also more focused efforts to increase grant writing skills for faculty from underrepresented background. So there have been several NIH initiatives to specifically recruit and train faculty from underrepresented backgrounds So we just put in a grant for that. So yes, the NIH, there were challenges, and in some cases there still are disparities in what's funded, but they're definitely taking steps to address that. They have a chief diversity officer. The first chief diversity officer was Dr. Hannah Valentine. She since I believe retired or has another position. They hired someone else. So this is the only second chief diversity officer at the NIH. So there have been more NIH leaders of color. So the current NIMHD, Dr. Perez Stable, is the director of the National Institute of Minority Health. Before that, I think it was like Dr. John Ruffin. So between increasing the number of applications, increasing training opportunities for faculty of color, diversifying the research administration at the NIH, and study sections, and those are the individuals who review your grants, right? And that is so important. That is so important, because if you have a group of people and they're listening to a grant and they have no idea that this is even a problem, but to have someone say, this is serious, this has important relevance, this is significant, right? And that changes the conversation. So it is, there are a lot of changes being made at the NIH. There really are. So if you're interested in submitting your grants, please don't let that be deter you from writing. They're taking a lot of steps to, Dr. Francis Collins has taken a lot of steps to really advance this initiative at the NIH. And also broadening health disparities grants to look at sexual, gender, minority health. That is really important. Where there's a lot of grants that look at gender-based violence, health disparities in transgender communities. So there are a lot of research. They've really expanded their portfolio in research opportunities. And one more thing, if you're working at an institution and there's a mechanism known as a diversity supplement. So if there's someone at your institution that has a large NIH grant, usually something called like an R01, or it's just a large NIH grant, they can add to that grant a trainee, right? And get money for that. It's a competitive award, which means you have to write for it, but they can help you write it and you can submit it. So if there's anyone with an R01 from NEI in ophthalmology, you can speak to them and say, can I write a diversity supplement on your grant? So those are mechanisms also. The NIH, if you do NIH research, that's an additional mechanism for loan forgiveness. So I really had my loans paid for because I did research, but it's an application process. So,
a quick question. It might be a dumb question, but like, how do we like get better at like writing and research? Because especially at this stage, is like an MS1 where you're interested in a project and then you kind of go to someone and you kind of hop on their project and you help and do like lit searches and things like that. So how do you like actually get better at like the writing aspect or the research aspect? Yeah.
Oh, that's not a dumb question at all. There are no dumb questions. Reading the literature, reading research that's already been conducted in that area, really reading it and seeing what they did. Writing the IRB. So if you have an opportunity to write an IRB, it can be like, oh, so, yeah, okay, nobody wants to write the IRB, so have the student write the IRB. But it's a learning exercise. It really is, because in the IRB, you have to write, what are the aims? Where is the methodology? So reading literature that's already been done, writing an IRB, writing abstracts. So if your institution has an internal abstract, internal grant, write abstracts. Right, write abstracts. Some of them will get accepted, some of them may not, but it's okay. Write your abstracts. So you write, improve your writing by writing more and reading what's been written.
All right, I'm going to put out a last call for questions as we are at 7 o'clock.
I do have a question, but I want to be respectful of your time. So if you have to go.
Good.
Okay. So again, I'm at Upstate, so I know it might be a little different like in the city. But I'm currently like on like transplant for surgery. And I guess I was wondering like your take, because I brought it up when I was speaking with like people like high up in transplant. And I stumped them when I asked them their opinions on like the elimination of the race-based coefficient. And I was just kind of shocked because I was like, wait, this isn't like a recent thing, like, and I guess I was just wondering, like, what do you think it will take for institutions to move forward with this? Because I mean, at this point, I was considering doing research and looking at pre and post, but I think my institution might be at the level where we're still pre that recommendation. So I might go through the data and sift through it and see, like, do we have, differences, ethno-racial differences in diagnosing CKD or like, further treatment or even transplants?
That's a great question. So we were able to do something. So we no longer used a race-based GFR. We're looking at other biological markers that we can use, knowing that race is not a biological marker. I just actually, Dr. Ernie Yap, I was really fortunate to really be included on a paper that he did, and we looked at the number of the proportion of people who would be placed at a more advanced stage of kidney disease if we remove the race-based algorithm. And it was like incrementally, it was like 15% would go from like stage like 2 to 3, and then like 30%, and then like 45 all the way to stage 5, and the implications that has. So I think one of the first things, like I said to Dominique, look at the literature, look at the data, look at institutions that have done it. Look at CERCA, CERCA. CERCA is the Coalition to End Race-Based Clinical Algorithms. That was a coalition started by the New York City Department of Health and Mental Hygiene Chief Medical Officer, Dr. Michelle Moyse. So it's a coalition of hospitals in downstate, like the local hospitals, not like, I guess, south of Syracuse, the local city department, and we did something, right? So it was so look at that, look at CERCA, CERCA, look at what CERCA was able to do and present that. The other thing is, it's timely because so Governor Hochul declared racism as a public health crisis in December of 2022. Many New York State, the Department of Health under Dr. Mary Bassett was also a part of that. Look at what they're doing, right? Look at what's happening nationally. Look at what University of Wisconsin, Wisconsin, I think it's University of Washington. They look at, I think it's University of Washington, race-based algorithm and a student-led initiative. I'm almost sure it's Washington. But yeah, you can Google it or just Google like student leads national initiative to remove race-based algorithms. Look at those papers, right? And share them with your department heads. And then the thing about it is what you're doing is you're not taking people off the transplant list, right? Some people may think that sometimes when you address disparities that, well, someone has to lose, right? That, well, if you're benefiting this group, that means this group that means there are going to be, fewer of this group on the transplant list, like it has to be a zero-sum game when it really isn't, right? It can be win-win, right? It can be win-win. And there's the cost, not only the quality, the chronic disease management earlier, but there's also a cost to people being on dialysis, right? And fewer people needing transplants, right? So look at the evidence, look at the data, look at the literature, look at the studies on why creatinine was thought to be to change by race, and it really, there was no basis for it whatsoever So look at some of the literature, have a journal club, right? Have a journal club about it. And make it a scientific exercise, not necessarily a confrontation, because sometimes people get defensive when it's a confrontation, you know, and I do too. Like, you're like, what are you talking about? Right? You don't know what you're talking about, right? But if you're like, hey, look at these articles, look at what the schools in New York City were able to do. Look at what the student was able to do. I think it's University of Washington. They were able to do. Bring the data, bring the literature, lawsuits, right? There's a lawsuit. There was a young man who is biracial, and he was told at one time he didn't need to be on the transplant. I think he had a change in provider, and then he was told that he was. And there's an actual lawsuit. There's a lawsuit that's out there, may not be the only one, right? So, you know, get your data together, and this is a learning exercise. Like, why, what's the scientific basis for this?
Thank you.
You're welcome.
Okay. Well, thank you all for joining, and thank you, Dr. Boutin-Foster, for leading this incredible discussion. It was wonderful. Again, for anybody who didn't hear the whole session, it will be recorded and we will put it up on the AMSNY YouTube channel. We also have prior webinars up there if you'd like to go back and take a deep dive on some of those. And we are looking forward to the next one.
And this is, research is fun. I wish I had time to tell you about the research study that I did with hip hop music. You'll have to email if you want to find out about it, but research is really fun. It really is.
So can we give out your email address to the
Absolutely.
people?
Absolutely.
All right, I will be
That was
following
fun.
up with Dr. Boutin-Foster's email, and we definitely want to see the abstract for the study on hip hop music.
Okay, I will do that.
Okay,
It's called the RAP study, the role of hip hop in addressing HIV and AIDS, done back in 2006. It was just fun to do it. It really was. I can share it with you.
great. All
Thank
right, well, everybody have a wonderful evening. Thank you.
All
Thank
right,
you.
thank you so much. I really enjoyed speaking with you, and please reach out.
Bye-bye.
I have a good one.
Bye-bye.